Welcome everyone to the September installment, whatever month we're in now, of this little bit of fun journey. So I'm actually going to start off today because there's actually some COVID stuff to talk about. Yay! And then we'll tear into the rest of the conversation from there. So for those who have been bored and didn't feel like we've gotten any new variants in a period of time, we've got some new variants. Lucky us. So for those who are keeping track at home, the EG.5 variant is the newest, most widespread variant in the United States, also in New York State. Sad news for those who are expecting something exciting. EG.5 is no more contagious, no more significant illness. It just happens to be the flavor of the month right now. So it is the most, EG.5, you want that variant? we'll put that in there for you. So it is the most widely circulating, understanding that the amount of testing and the amount of samples being subtyped is nowhere near what it was, say, a year ago. But the one that is getting interest at the moment is BA.2.86, which again is a seemingly, it's Omicron that has Frankensteined with an earlier version of the COVID virus. So it has a whole host of mutations along the spike protein and even some of the receptor sites. So it is of interest because it has more mutations than any of the other variants that have been seen to date. So many that they're actually thinking about pulling up another letter of the Greek alphabet. So we might go past Omicron and get to Pi finally, which would be very exciting for the end of 2023. But nonetheless, we have not pulled Pi out yet. So possibly coming to a theater near you in the near future. The good news is BA.2.86 has not been found in the Rochester area. My understanding is there were 2 cases in New York City. That does not seem to date to be any more contagious. There was one report that potentially it is causing more severe manifestation in the elderly population. But it's still pretty widespread when you look across the global health organizations, that it's very scattered as far as the appearance of that particular variant. So it is on the WHO variant of interest. It is still thought that the EG.5 and BA.2.86 would both be responsive to the current boosters that are available. So as folks probably saw yesterday, the FDA has approved the new booster. They are recommending anyone above the age of, I think, 6 months who has not received a booster within the last 6 months would get the new booster. So that booster would certainly seem to cover both of these new variants that are in existence. There has been some question about whether this booster was going to be the kind of annual flu vaccine of COVID. That does, although they have not explicitly come out and said that that is the plan, and I think they're probably reserving that because of these new variants, that there's some concern about whether it may take a more targeted booster approach. The intention previously had been that indeed would be the case, that this would become a annual, I'm going to come back to that one in just a second, that this would be kind of an annual re-up of your booster. So for right now, the answer would be yes, this is the annual booster. To the question that was just put in the chat, can you get them at the same time? This all depends on how much of an immunology nerd you really are. So if you are not an immunology nerd, yes, it appears that you can get them at the same time. And probably that is going to be more effective from a population health perspective because you have someone in front of you that's willing to get jabbed with a sharp object, although obviously it would be 2 sharp objects because they have not come up with a combo booster, influenza and COVID to date. If you are an immunology nerd, there may be evidence to suggest that giving your immune system one thing to focus on at a time, spread at least by 2 weeks apart, may be most effective in improving the immunogenicity of the vaccine booster. So I say all that to say, it may be sound cool that I knew the word immunogenicity and I could say it without stuttering. So I got that out. You're welcome, Mom. But the reality is, I don't think there's a whole lot of evidence outside of like journal articles and people at ID conferences and cocktail parties that probably care. So I think it's probably perfectly fine if someone were so disposed to get them both at the same time. But if you really want to go for the win and separate it by 2 weeks, sounds great. Knock yourself out. Certainly, there is the expectation, because we are seeing cases and hospitalizations nationally going up, that we may see a kind of COVID fall and winter where we see a little bit more of a boost of patients being hospitalized. I will say locally, the general consensus is that we are seeing a higher number of people who are being hospitalized and being found to have COVID, not being hospitalized because of COVID. So the severity on most patients, they are asymptomatic from the COVID standpoint. They come in with something else and are kind of found to be COVID positive on testing. So it still does not seem that we're seeing an increase in severity of illness at this point, at least in the local community. And as I said, it's really only scattered reports that show some potential increase in the chronically ill elderly population of severity of manifestation. But if you look at the hospitalization numbers, it still pales in comparison to where we were, certainly a year ago. So for right now, I would say the booster we have is the one we're going to have. It seems to be effective. The variants are fun to talk about at the cocktail parties with the ID nerds, if you could say immunogenicity. But the boosters will work. And it does seem, if you want to get both boosters simultaneously to get all of your sharp objects out of the way at one time, it is probably perfectly reasonable to do so. But if you really want to go for the win and spread them out by 2 weeks, knock yourself out. The other thing that comes up, one person had asked specifically about recommendations of timing, people that are going to have family in town, they're going away for vacations. In general, the evidence for the booster is that you start to see the spike in response in about 7 to 10 days. So generally, my recommendation to people is get the booster 2 weeks before you're going to do something really exciting. So if you're going on that cruise around the world, or you're going to stand inside a theater for 8 hours straight or something like that, and you're going to be in close confines with somebody, generally getting the booster about 2 weeks before that would be the best chance of optimizing your immunogenic response prior to that exposure. So that is where we stand. The other thing that has come up is around masking. So folks may have seen that even upstate, there have been a couple hospitals that have gone back to masking protocols, largely because we are not seeing the severity of illness, and nor are we seeing that significant of an increase in hospitalizations. Many of you know that the hospitals here, we have kind of left masking standards in place to where if you come into contact with patients on the inpatient setting, masking is still required, but it is optional elsewhere. We are not changing that within UR, and I think Rochester Regional is on par with that. We are not going back to any universal masking requirements. We all still do offer masks available to patients and visitors when they come into the hospital. We do require them if they're, if obviously we require them of staff if we're going to go into a room to see a patient, but we're not requiring the individual visitors and all that to mask. So right now, we just talked about that, I think it was Monday, and agreed that we're staying with that for the time being. Obviously, if the world changes, we'll be revisiting that, but for now, there is no plan to go back to any universal masking requirements in the hospital setting. Obviously, in the practices, there's not universal masking. We have some isolated reports of providers that are requesting that their patients mask. We do have patients that request that providers come to mask when they see them. I think those are generally being handled without much fanfare to date. But none of the practices I'm aware of have gone to a universal masking standard that I've heard at this point. But certainly, obviously it's within everyone's right to do so, especially in the private practice world. But there is no push from any regulatory agency to go back to a mandatory masking policy at this point. And I think given the political landscape of the world, that's unlikely to happen unless we see a significant change in illness or infectivity. Changes to isolation guidelines. I have not seen any update or changes to this point. So we're still under the same guidance we were before, that you should be 5 days isolated if you have COVID, and then come back with an N95 if you're going to work. for at least that 10 days before you go back to general population kind of risk. So that stays the same as well. Okay, that's my new and exciting COVID update. So yay, EG5 and BA.2.86 for those who want to carry that around for a little while. And get your booster 2 weeks away from your flu shot if you really want to be nerdy. Otherwise, just get them and everybody will be happy. So that's the end of that story in a nutshell. Now I'll shut up. Who's going first now? LJ, Renee, Jana?
I'm not speaking, but I do believe that Elizabeth is going to come up with us next to talk about quality measures.
Perfect.
I'm a surprise guest today, Chad. You didn't know I was going to be talking. So I am going to share my screen with you all and just take a brief minute to walk through a couple of areas of focus for AHP for the end of the year. Let me do this. Screen one today. All right. Here we go. That's not helpful. Hang on for just a moment.
Just go to display settings and change it to.
Where's display settings? This one?
Screen.
Oh, thank you.
There you go. There you go.
Fabulous. I don't even have 2 monitors up today. That's why that was so confusing for me. So I just wanted to give a brief performance update, like I said, for a couple of our quality measures and then talk about the focus. General overview, the quality measure points that we are looking at. So I am talking here about our commercial, our Medicare, and our Medicaid population, giving everybody a little bit of a view behind the scenes. We are still looking, I'm just going to reiterate at the beginning of this, we are still looking for our providers to be looking at their entire population. But we wanted to make sure that we make clear to everyone how we're performing on our different contracts at the AHP level. So we are performing on from a year perspective, on our commercial population, we've achieved 83 points. Medicare is 94 and Medicaid is 68. On a trailing year basis, both commercial and Medicare are above that 90-point threshold. So some of one of the important things to keep in mind as we look at our quality measure performance is the difference between the year and the trailing year. We don't expect the year to be at our full performance at this point because we are in fact not done with the year. So that's where that trailing year view comes into place. Our Medicaid performance is sitting at 77 points from a trailing year perspective. We really want to get above that 80-point threshold. For commercial and Medicare, we're above the 90-point threshold on a trailing year basis. We want to make sure that we end the year above that 90 points. So we still have some work to do in the commercial space to get there, but we feel pretty good about that. We have a couple quality measures that we are focusing on that we're looking to move the needle on between now and the end of the year. I'm going to start out with our adult focus measures, and then I do have a pediatric measure at the end of this. So colon cancer screening, our current performance for commercial, we're at the 90th percentile, Medicaid at the 25th, and Medicare at the 90th. We did see a big drop in our commercial and Medicaid performance this year. So commercial, we actually dropped 6%. We're still above that 90th threshold, but we lost a fair amount of ground in terms of total patients captured. And the primary challenge we're seeing here is a drop in the age threshold. So it's no longer age 50, it's now age 45. A full third of our open gaps are in that 45 to 50 years. And the whole quality measure denominator is 45 to 75. So you can imagine that a full third of that being in the first 5 years indicates that's a pretty big issue. The challenge, the second primary challenge, I guess, the real primary challenge here is the patient willingness to engage in care, particularly in that 45 to 50-year-old cohort. As of last year, they may not have known that they were going to qualify or be recommended for colonoscopies. As of this year, they were probably waiting until they turned 50 to have that conversation with their doctor. And so we are now looking at a whole new cohort of patients. Additionally, there's that group above 50 who just doesn't want to get a colonoscopy, or maybe doesn't want to engage in a fit kit or Cologuard. So the action that we're taking here to try and move the needle, particularly in that Medicaid population, is direct patient outreach, direct practice outreach. The goal being learning about what's happening in practice. We want to highlight the importance. I think colon cancer screening is pretty understandable to our providers. Everybody knows that it's a thing that we should be looking at. But highlight the importance, particularly in that age range, and see where AHP can help, where we can support efforts. We did do a fit kit initiative back in the before times. I think it was 2018. Chad's nodding like some, wise man sitting in his office. So if folks want to consider re-upping that, if it's not still top of mind, I'm happy to discuss that. We've learned a couple of interesting things in our discussions with the practices that we've connected with already. One of our practices, as one of our systems, has opportunities for PCPs to directly schedule their patients. So not just calling a specialist, but actually getting the patients on the calendar and scheduling that appointment for them, and potentially scheduling follow-ups. If there's no calendar restrictions, you can schedule a follow-up for that 5-year or 10-year, next colonoscopy if someone's coming in. I think it'll take a little time to see how effective that is in impacting numbers, because we were talking about 5 years from now. But I still think it's an interesting thing to kind of get the patient on the calendar. I'm going to pause here for a moment and see, does anybody have any questions? I don't know if anything's coming through the chat. Nope, Chad's just talking about variants. Okay. I'm going to jump to our diabetic measures. I have A1C here and diabetic eye exam. So this is another area of focus for us. A little bit more challenging than colon cancer screening from an A1C perspective. Because for colon cancer screening, you have to go and get the thing and then you're done. You check the box. For A1C, you have to go and get your A1C done and it has to be controlled. So our current performance, you can see, is not great from a percentile perspective. We're at the 25th percentile for, brief moment here. These are year numbers. So we are looking at 2023, which is part of the reason that some of these numbers look a little bit lower. We have not seen all of our patients yet. We anticipate some of these quality measure gaps will close in the normal course of business. I should have written that down on the slide, but I just wanted to caveat that for folks. So you can see where our performance is. The primary challenges that we're seeing here are threshold increases. So we've seen the threshold go up. We've had a small decrease in numerator compliance. And we think that the medication-only patient qualifications may be impacting that in a larger way than it has in previous years. We anticipate that trend to continue too. From a diabetic eye perspective, again, you can see the numbers. Again, they are on a year basis. We have seen some threshold increases, not as dramatic as on the A1C, but access and patient engagement. This has been a measure we've struggled with sort of historically, making sure that patients are getting in, that they know that they have coverage, that they're getting an actual diabetic retinopathy, as opposed to an eye exam that doesn't include that. From an action perspective, we spent a little time parsing out this data. So as I mentioned, there's a little bit more to the A1C in particular. We wanted to understand the breakdown of the gaps. So those who are high versus those who are overdue. It's obviously a very different intervention. And then understanding the impact of that medication-only diagnosis. So someone who has been prescribed a drug that is considered a diabetic drug and is falling into the diabetic denominator, but may not have diabetes. They will still be counted towards that HEDIS definition, but we won't be getting an A1C or a diabetic eye exam for them. What we're doing here is looking to leverage our AHP resources, data coordination, care management, our AHP pharmacy team. We are definitely interested in partnering with folks in this space. So you will certainly be hearing more from myself and my team in the weeks to come. And then the final thing I wanted to mention was adolescent immunizations. We're doing quite well in the commercial space. Medicaid leaves a bit to be desired. We're focusing here on HPV vaccinations. We've actually created some actionable patient lists, and I parse this out in 2 different ways. So I consider the quality gap closure. So patients who can still achieve gap closure, who have had that first HPV vaccination, have enough time before their 13th birthday to get the second. And then the clinical gaps. So patients who may have aged out, but who are still missing a vaccination, we want to be able to provide our pediatricians with those lists as well. It's not going to close the quality gap, but from a clinical perspective, it's still important to close the loop there. So we're going to be working over the next, hours, days, and weeks to get these lists out to practices who are interested in seeing them. I know that a lot of our practices have really, quite frankly, pretty robust immunization registries. So we don't need to badger anyone, but if this information would be helpful, we're happy to provide it. And that's all I had on quality gaps. Does anybody have any questions?
Okay, no questions in the chat. So we have a quick agenda update or deviation, I should say, and LJ is going to talk a little bit about RSV and some of the coordination events in the community. Take it away, LJ.
Did Jana just call me a deviant? Is that what I heard? Yeah, you heard that too,
Yes,
right? Okay.
you did
All
hear
right.
that correctly.
Wow. I'm going to wear that title proudly. No, so what I wanted to do, because I recognize we have many of our pediatric and family medicine practices on the call today, just wanted to give you a little preview into the community-wide discussions that are happening around nirsevimib, or the RSV immunoglobulin or monoclonal antibody, or vaccine, as everyone's calling it, the RSV vaccine. So very briefly, with approval of this vaccine, the recommendation is for healthy infants to receive this, infants 8 months of age and younger, and ideally within the first week after birth. That's for all children. And then special recommendations for children 8 to 19 months of age who are at increased risk for severe RSV diseases, who are entering their second RSV season. I know many of you have already read and you know all of this, but just to give a couple of bullets, the impact of this is a significant risk of both hospitalization and healthcare visits for RSV in infants by about 80%. So the effectiveness of this is quite significant. Rolling it out is going to be quite a feat, and it's requiring a lot of coordination because this is a very costly product. As many of you know, we haven't heard final cost yet, but it's in the range of $500 per dose. So I just wanted for our practice teams to know that you were very well represented by several of our primary care providers who joined this call. You were represented at a community-wide meeting that was held about 2 weeks ago to look at how could we do this in the most effective fashion and what were the barriers that we needed to be cognizant of. And at this point in time right now, we are looking to coordinate a regional approach to this, whereby all of the birthing hospitals would work to be able to do administration for infants before discharge from the hospital, which just makes sense from a public health standpoint. But there are a number of factors. The reason you haven't heard something announced about this is because there's a number of factors that everyone is still waiting for. This is going to require, there's ongoing conversation and coordination between the New York State's VFC program and the CDC. Knowing that more than 60% of newborns are on Medicaid or would be eligible for vaccine through the VFC program, we have to have a robust response and plan from VFC. The majority of community hospitals do not participate in the VFC program, but we know there have been exceptions in some cases, for example, with the Hep B vaccine that is given in the hospital setting. So more to come on what that will look like, but the goal, obviously, from a national rollout, statewide rollout, and from our region is to do as much of this work in the birthing hospital setting as possible. But that still will leave children who will require vaccine from another source, so from either their primary care practice or otherwise. So I just want to say, we have heard that the major insurers will be covering this, and we do not know to what extent the administration and counseling fee, what that will look like, although the AHP is certainly advocating for a reasonable administration and counseling fee reimbursement. But we also recognize that this is not the time where our practices can put out X dollars, incredible number of dollars to be able to have this in stock. And so we're also trying to look to see what will be needed for that rollout. And Galsano Children's Hospital is looking to see if it is needed to be able to support some of this from a community standpoint, similar to the way that COVID vaccine was supported. So stay tuned. That was a lot of, I don't have the answers to any of this, but the good news is, like, people were meeting. Actually, our community is informing the New York State VFC's program and New York State Medicaid, because we already met, I think, as they were meeting, and we keep feeding them information about barriers and what would be important to have in place so that we could actually do this effectively. So you'll get more messaging that will come out. You're probably going to get a little survey from us. I'm just going to alert the practice managers, because we really would like to know how many practices would feel like there's just no way that they could do this. And I think that could be a number of practices. So for planning purposes, if you don't mind, there'll be a short survey that's going to come out. And this same messaging is being conveyed. When it goes out, it's going to go out together with our colleagues at Rochester Regional, with our colleagues within the federally qualified health centers and other hospital systems. So we're all looking at the same approach for kids. And I just want to let you know there is work going on in the background, because there's a lot of questions and a lot of concern, I know, on the part of our pediatric and family medicine teams. So I'm happy to entertain any questions that I probably can't answer, but yeah, there's a Lisa Genesi just put in there. Lisa, I don't know if it's a new administration code, but the AAP is there was a message that came out from the president of the APP or the AAP, excuse me, that they're advocating specifically for a very reasonable, I would think a higher counseling and administration code, because this will be a lift. So we'll know more about that. That's, it's like everybody's putting out bullets to say we're working on this, but I think everybody's working on the right thing. Any other questions? If you do have specific questions, feel free to email me. I might loop you into more of a loop with other folks, but our pharmacy teams, the hospital administration teams, Tim Stevens is doing a lot of leadership in this place, and clearly our newborn nursery directors and NICU teams are all very actively involved, and of course our ID folks. And we'd love to maybe bring to this group in another month, when we're closer to knowing exactly what this is going to look like, we'll bring in some of the ID experts and actually talk about it a little more and answer your questions. Yeah.
Anything else on our agenda, Jamie?
There are just two more things that we'd like to do. The first one is very quick, and I will do that, which is just a reminder about next week's practice managers meeting. That is next Wednesday at 8 a.m. from 8 to 9. We will get the agenda and invitation for that out to practice managers this week, so you will see that. But it is next Wednesday morning, 8 a.m. to 9 a.m. on Zoom. And then the very last part of the agenda is just having some open dialogue about this call, the future of this call, why people still log on, what you're looking for, what you enjoy, and what you'd like to see more of. So we would like to invite folks to talk about that now. But if you want to share, private feedback, you can always reach out to any of the folks here at AHP about this, and we can definitely have that conversation. So I will give folks a minute to come off mute, add anything into the chat about that.
I think our big question in regards to this is, obviously the COVID information is diminishing compared to when we started this meeting. We've steadily ramped down the intensity and frequency as that information has declined. We also want to be respectful of everyone's time. We realize that no one's just sitting around twiddling their thumb in the middle of the day, wondering of things to do. We could always pull this meeting back together if folks did not feel that it was helpful. However, I think we have developed a friendship around our little fireside chats. So if there is information that you would see beneficial, or things that you would like to bring into this forum, now that we do have this kind of continuity of togetherness, then certainly we want to make use of that time and be most efficient with it. And obviously, if the world changes with COVID, then we would reenact the prior plan as quickly as we reenacted this one.
Okay. So yeah, if you have any feedback, anything that you'd like to see here done differently, you can share that with any of us by email or giving us a call. I did just also want to point out LJ's answer to Lisa's question, that the AAP is advocating for a brand new administration code regarding the RSV vaccine. And so that is what they're working on. That brings us to the bottom of the agenda. I'll see if anyone has any last minute things they want to add in. Nothing from folks here?
Nothing today.
Okay. Then with that, everyone will get 5 minutes to scarf down a lunch before their 1 o'clock meetings.
Thanks,
Thanks for
everybody.
Take care,
joining.
everybody.
Take care.
Bye-bye.